Hello and welcome to this lecture on patient-specific dosimetry and absorbed dose-effect relationships for I-131 therapies. My name is JanTaprogge and I'm a medical physics expert at the Royal Marsden Hospital. And I very much would like to thank my co-author for this presentation, Dr. Carlo Chiesa from Milan, who has helped me to put together all of the slides that you're going to be seeing in the following, and has tried to help me to figure out what is what has been done in the way of patient-specific dosimetry and what do we know about the absorbed dose effect relationships and their implementation in the clinic. We have nothing to disclose in relation to this presentation. So it all started off a long time ago with radioiodine. It really is like the starting point for molecular radiotherapy. And it all started in 1936 with an MIT lecture by Carl Compton, where he talked about potential applications of radioactive substances in medicine. And Saul Hertz, the director of the thyroid clinic at MGH, was there at the time, and he asked, could iodine be made radioactive artificially? And then just 5 years later, it was used in the clinic for the treatment of both benign thyroid conditions, so hyperthyroidism, and thyroid cancer. And there's some other I-131-based therapies out there as well. So we've got I-131 MIBG for neuroblastoma, and then, for example, I-131 tositunimab for lymphoma. So it has been really around for a long time. And so, yeah, like I said, so one of the applications where we use I-131 is obviously thyroid cancer. So differentiated thyroid cancer is really one of the most common endocrine malignancies in the world. And normally what happens is that the thyroid gets removed and then potentially followed by radioiodine treatment to ablate any residual thyroid tissue, usually with fixed activities of 1.1 or 3.7 gigabecquerels. And then if the patient has metastatic disease, they usually get given higher activities from between 5.5 to 11 gigabecquerels. And there's really two dosimetry concepts that come in here, some of which have been presented in some of the earlier lectures. So the approach that has been around the longest really is the MTA approach, the maximum tolerated activity approach. This is where we try to minimize the risk of any toxicities to normal organs by administering the maximum amount we could safely administer to an individual patient by keeping below any kind of dose thresholds. And then at the other end, we have the thyroid remnant or lesional dosimetry approach, where we try to improve the treatment by delivering a certain absorbed dose to lesions or the thyroid remnants to improve outcome for patients. And this is just putting them next to each other. So you've got the maximization approach, where, like we said in earlier lectures, we don't normally need imaging. It's only whole body counting and blood samples, and we can really give the maximum amount necessary, but it might be too much. I mean, we might be giving more than we need to the lesions or something like that, because we're really focusing on the normal organs. Or the optimization approach, on the other hand, so where we're treating to a lesional dose, it's really it obviously requires some kind of imaging, and it's often impossible to measure the target masses. So that's one of the problems, especially if we're talking about thyroid remnants, which are just small amounts of residual tissue that is very hard to quantify the amount. Then the other problem is that we obviously, if a patient has multiple lesions, normally they will receive different amounts of radiation, different absorbed doses. So it's very hard to prescribe to a certain amount of absorbed dose. And then even within a lesion, they can be very heterogeneous, the uptake and therefore the absorbed dose. So some of the considerations we have to do when we are talking about thyroid cancer, is that when we treat those patients, normally we're trying to stimulate their TSH levels, their thyroid stimulating hormone levels, to increase radioiodine uptake. We can use two different regimens for that. Either we can make patient a euthyroid regimen, where we give them rh-TSH, so an artificial TSH, or we can withdraw their thyroid hormone prior to therapy, so then they are treated on a hypothyroidism approach. The main thing here to mention for dosimetry is really that both, if you do pre-treatment dosimetry, it must be done in the same hormonal regimen as therapy, because it very much can change the uptake and the half-lives and everything in the lesions and the targets. So first of all, let's look at thyroid remnants. So that's why we've taken out our thyroid and then treating our patients to kind of like ablate any remaining tissue left. Well, there's kind of like two papers that have been mostly cited for this, which is a paper from 1983 by Maxon et al., where they looked at 30 patients and they used a rectilinear scanner, and they found that to achieve successful ablation, you required a minimum of 300 gray to the thyroid remnants. Flux et al., on the other hand, in 2010, they did 23 patients. They had SPECT scans at up to 4 time points. What they did was, instead of like doing the absorbed dose to the whole thyroid remnant, they did the maximum absorbed dose to the thyroid remnant. So to kind of like avoid this problem that we have an unknown volume. And they found that to achieve successful ablation, you need at least 49 gray. And then if we go away from the thyroid remnants and we go to the metastatic patients, we've got very much the two approaches being used. So we've got the MTA approach and the lesional dosimetry approach. So this paper by Lee et al. From 2008, they kind of like used the MTA approach. So they tried to like give the maximum amount without giving less than 2 gray to the blood. So kind of like limiting the blood absorbed dose. And this was 47 metastatic patients that had previously been non-responsive to fixed activities. They were now given activity based on the MTA approach. And you can see there in the graph kind of thing that those patients that previously had been non-responsive to fixed activities, a large proportion of them were either had complete remission, partial remission, or stable disease, and only very few had disease progression. So kind of like given an indication that the MTA approach here might have really changed the patient management. Obviously, some of those patients had kind of like normal organ toxicities, with some of them, so 26 out of the 47 had like blood count abnormalities that recovered after therapy, and 3 had blood abnormalities that didn't recover back to the baseline values. Then there's this paper as well from Global et al. Where again, so they compared the MTA approach to an empirical approach in 2 different centers. So one center did the MTA approach, one center did the empirical approach, and they looked at like overall difference in like complete remission, partial remission, stable disease, and disease progression in the 2 different groups. Overall, they didn't find any difference in the progression-free survival. But when they looked at like special subgroups, so the local regional advanced disease group, they found that the MTA approach actually performed significantly better. So overall, they reported a high efficacy for the MTA approach while having a very similar safety profile. And then we obviously, on the other hand, got kind of like the lesional dosimetry approach. And so these are like, yeah, on this slide, I've got 2 of the papers that looked at like what kind of absorbed dose is needed to successfully treat those metastatic lesions. So the earliest work was by Maxon et al. In 1983, who found that 80 gray was needed to metastatic disease to kind of like get a significant increase in the rate of therapy response. And then Wirtz et al. In 2016, they performed I-124 PET-CT pre-therapy dosimetry, and they found that the optimal threshold value of 40 gray was needed for metastatic disease, and as well in their paper they found that 90 gray was needed for thyroid remnants. And then there's a couple more papers by the Jensen group. They published 2 papers. One very much focused on like soft tissue lesions, so lymph nodes or pulmonary metastases, and then another later paper on bone metastases. And they found that if they used an absorbed dose threshold of 85 gray in the kind of like soft tissue lesions, they found like response rates of 63 or 88% respectively for lymph nodes and pulmonary metastases. And then the graph that is shown there is from their paper about the bone metastases, showing that kind of like for the 85 gray absorbed threshold that they had for their like lymph nodes and pulmonary metastases, they only reached about like less than 50%, and they said that to get to response rates of like about 70 to 80%, you actually need between 350 and 650 gray to the bone metastasis. And so obviously something that I've mentioned before as well in some of my other talks is kind of like what data is actually needed, and lots of work has been going on into like optimizing imaging schedules, because obviously, as we know, we need serial quantitative imaging for dosimetry, which means patients might have to return to hospital after discharge to get like those enough data points in there, and especially to get kind of like sample like the slower retention at the end of the curve. And but like I said, there have been lots of people have been working on this, and like one of the papers is by Jensen et al., who compared for iodine patients 5 imaging time point protocol compared to 2 or 3 imaging time points, and they found that 2 or 3 imaging time points actually can provide a reasonable accurate estimates, and like the mean absolute deviation was only about 16%. Something else to consider for the lesional approach very much is that there is some evidence in the literature that if you do an unsuccessful fixed activity the first time around, you potentially reduce the uptake in the next administrations. So this is some data that was published by Bianchi et al., where they looked at the lesional doses across multiple cycles, and so you've got the like 15 lesions here on the graph, the absorbed dose on the y-axis, and you've got like in blue cycle 1, in purple cycle 2, and in pink cycle 3. And you can see that for most of the lesions, and this is you have to see that this is like a log scale, like the dose dramatically decreases from the first to the third cycle, and there's only very few lesions where it actually goes up or stays similar. So it might be very, very much important to do like a first proper hit and not kind of like go in with multiple administrations. So another bit where we've looked at like dosimetry for thyroid cancer patients is in refractory disease. So lots of our thyroid cancer patients, once they have become metastatic, they will be giving like over and over radioiodine again, and the majority of those patients eventually will become refractory to the iodine, so the disease will evolve so much that it doesn't take up any iodine anymore. So there's a couple of studies out there that have looked at implementing like new treatment schedules where we try to resensitize those patients to further radioiodine treatment, and that have also incorporated quantitative imaging and dosimetry. And all of this was done in the kind of like refractory setting for patients treated with silometinib. So there was an initial study by Ho et al. And Sloan Kettering, and this was then repeated or extended by us as part of the phase 2 telemetry study, where we looked at 30 patients that were giving silometinib to resensitize them, and was one of the main goals of the study was really to look at the dosimetry and the effect that we could do with quantitative imaging. So I'm going to be a little bit more going into detail here just to show you kind of like what a pre-therapy and post-therapy dosimetry schedule can look like, and kind of like look at what the potential effect can be and how it could be used potentially in the future. So this patient in this study had a quite intensive imaging schedule. They started off with an I-123 scan just to confirm that they were iodine refractory, and then we're giving 4 weeks of this drug that tried to resensitize them to take up iodine again. They then had a second I-123 administration, followed by a 24-hour scan that was used to kind of like compare to the baseline uptake, just to see if the selumetinib has worked. But it was very much surrounded by additional SPECT-CT scans to perform kind of like your pre-therapy dosimetry. And then if they were deemed that the selumetinib had worked, they went into like an I-131 therapy, followed again by dosimetry. So lots of the work that we did there was kind of to see, can actually the I-123 pre-therapy accurately predict the I-131 therapy administrations, or like the absorbed doses that we deliver during that administration. And this is what we found was that like, so if you've got on the x-axis your predicted absorbed dose pre-therapy, and our y-axis the absorbed doses actually delivered post-therapy measured with our dosimetry scans. And you can see that there's a very nice correlation between the two. There is, like as you can see, it's log-log plot, so there is quite some deviation from the line, but it also kind of like shows, so we did full uncertainty analysis here, so it's really important that you do uncertainty analysis, that you quantify how certain you are on your doses that you're reporting, because if you're looking at the uncertainties, actually the majority of those points actually lie on the line of identity. So it's really important for your clinician to know how certain you are about the doses that you're reporting. So I'm moving away now from thyroid cancer, and I'm just going to focus a little bit on hypothyroidism, because that's the other bit where radioiodine has been really extensively used in the past. And there are two types of benign thyroid conditions: hypothyroidism, where the thyroid is overactive, and hypothyroidism, where the thyroid is underactive. And hyperthyroidism has really been widely treated with I-131 since like 1941, like I said earlier. And so there's two aims of treatment. Either you try to achieve hypothyroidism, where kind of like you're trying to distract the gland, use kind of like a fixed activity approach, normally no dosimetry, or what you can aim for is euthyroidism, kind of like a normal thyroid function. And the difference really is that if you're making a patient hypothyroid, they require lifelong thyroid hormone replacement. Unfortunately, dosimetry is sometimes used, but normally it's still very much a standard level approach. But I'm going to show some data now that we have found when we did a systematic review that really highlights that dosimetry can help in this patient, and there's very much a well-established dose-response relationship. So we kind of like did a systematic review to see if there's a relationship between the absorbed doses delivered and the outcome for Graves' disease patient. Found quite a lot of study, and total like boiled it down to about 15 that had actually dosimetry and outcome data, with a total of 2,303 patients. And when we looked at kind of like plotting the absorbed dose and the reported in the studies versus the response fraction, you really see this nice dose-response relationship, and showing kind of like the population fraction achieving cure after a medium follow-up of 12 months. So really showing that, yes, there is a dose response here, and like dosimetry really might make a difference here. Then, like I said earlier, there's other therapies where we have used dosimetry before, mostly I-131 MIBG, and if you look into my lecture on whole body and blood dosimetry, I've talked a lot about that. All of that is mostly about the MTA approach, so we're treating to like a whole body absorbed dose, normally of 2+2 gray. So yeah, so look into the other lectures, and hopefully you're going to find everything there. So yeah, just to summarize, so I think treatment personalization for using I-131 for either thyroid cancer or benign thyroid disease, and for I-131 MIBG for neuroblastoma, really I think is feasible. We have shown that pre-therapy dosimetry can predict post-therapy outcome, and we have shown that there is dose-response relationships. There's quite a lot of papers out there reporting different kind of absorbed dose thresholds, even if they're a little bit variable. I think we still can see that there definitely is a value of adding dosimetry, and there's different clinical scenarios. I think what really needs to be done now, and this is really like where I'm hoping the younger generations come in kind of thing and can help us. We really need to expand the literature on treatment planning, long-term follow-up studies for larger patients, especially for thyroid cancer, to kind of like find what is the optimal dose for those patients, and kind of like standardize things so that we can actually move this into the clinic. So yeah, Thank you very much for listening, and I hope you've enjoyed this talk.